Okay. Now I will share my screen again. Okay, so today we are going to end all of our lectures with heart failure. Heart failure is probably one of the most chronic health problems, one of the most common diseases that you see or take care of in the hospital. Sometimes it's referred to as heart failure, but what it is the heart, it's the inability of the heart to work effectively as a pump. It occurs in hospital patients mostly over the age of 65. And when your heart is unable to pump effectively, it's unable to pump oxygen through the lungs and throughout the rest of the body. It usually is a slow process. It occurs over a number of years. This is something that patients just one day and they have heart failure. So the result is inadequate cardiac output. It could also cause myocardial hypertrophy because your heart is like a muscle, and the more it pumps, the harder it pumps. Kind of like when you lift weights, your muscles get bigger. So as your heart has to work harder to pump, it's going to get bigger. It's going to
Julie, Julie, you're cutting out, and I think it's because Kenny's not muted.
Okay. Who needs to mute? Can you hear me?
Yes.
You're better.
Okay. Okay, is that better? Okay. So some underlying conditions that cause patients to go into heart failure could be acute or chronic cardiopulmonary problems. Patients who have had an MI are more likely to have heart failure. And then some other structural or functional problems of the heart that can also cause heart failure. Now, heart failure can be acute and it can also be chronic, and both can be life-threatening if the patient does not respond to treatment. There are two types of heart failure, left-sided and right-sided failure. So with left-sided, it's formally known as congestive heart failure. I don't think they refer to it as that much anymore. But left-sided is heart failure that the left ventricles cannot adequately pump blood out to the body, and so the blood begins to back up into the lung, making them congested, and so that's where they get the name congestive heart failure. So an easier way to remember what is affected from left-sided heart failure is it affects the lungs, so left lung. That's how maybe you can remember it a little easier. Some typical causes are hypertension, coronary artery disease, angina, patients who've had an MI, and then valvular disease. So when you are thinking about your patient and the history, it affects two areas in the body. It decreases cardiac output and it causes pulmonary congestion. There's a chart on page 695 that you may want to look at. It's chart 35-1, and it talks about these two areas. The most pronounced symptom of heart failure is dyspnea. Patients are usually extremely short of breath. So you may ask them, you know, how many pillows do you sleep on at night? Sometimes they may sleep on 2 to 3 pillows. They may have orthopnea, inability to breathe when they're lying down. They also may have the PND, the paroxysmal nocturnal dyspnea. This is episodes of shortness of breath at night, and it may not be relieved by sitting up. And then they also have extreme exertional dyspnea, or dyspnea upon exertion, whichever way you want to say it. They fatigue very quickly. They run out of breath very quickly. They have to have frequent rest times. They're also going to complain of weakness, again, the unusual fatigue, even taking a bath, eating. Those are just very difficult for patients who have heart failure. And they may also be dizzy from the palpitations. They could have a fast heartbeat. And then they also may have a cough that accompanies their heart failure from all of the pulmonary congestion. With decreased cardiac output, other than fatigue or weakness, they could have oliguria during the day. That means they have scant urine output during the day, but then at nighttime, they may have to get up frequently and go because you usually diuresis through the night. They also may have angina, some confusion and restlessness. And with our older patients, it's good to objectively assess them on their confusion. Of course, you can ask them, you know, do you know where you're at? You know, what's your name, date of birth, those things like that. But older people sometimes get really good at covering up their memory loss because they know that they're forgetting things. And so it's real good just to do an objective assessment and see if they're confused. And the reason they have a lot of confusion with heart failure, of course, is because the hypoxia. They also may be tachycardic. They may have palpitations. When you are checking their apical pulse, a lot of times I said that with heart failure, your heart is going to get big. It's going to have cardiomegaly or hypertrophy. So the apical pulse might be displaced when you go to check their apical pulse. It might be more to the left than you are used to finding it. So just keep that in mind when you're doing your assessment. Patients might be pale, their peripheral pulses might be very weak, and then patients can have cool extremities. When we think of the pulmonary congestion that goes with left-sided heart failure, they have that hacking cough. Usually it's worse at night. Again, they're very dyspneic and they're breathless. A lot of times their respiratory rate will exceed 20 breaths per minute. So don't be surprised if they have a high respiratory rate. When you also take their lungs, you're going to hear lots of crackles or wheezes. A lot of times, if a patient has crackles or wheezes, you can have them cough and that might clear their lungs. With heart failure patients, if they cough, it doesn't help to clear the lungs. They just continually wheeze and have crackles. They may also have a frothy pink tinged sputum, tachypnea, and then they may also develop a gallop in their heart. So this is just kind of a picture of this little man. He has left-sided heart failure, and it's just to help you see all the different effects that left-sided heart failure would have. Okay, now let's talk about right-sided heart failure. Right-sided heart failure is systemic congestion, and it occurs because the right ventricle fails, fluid is retained, and then pressure builds up in the venous system. Right-sided heart failure can occur as a result of left-sided heart failure. However, a patient with severe lung disease can also experience right-sided heart failure because the heart cannot pump the blood good through the diseased lungs. The most obvious symptom for right-sided heart failure is the buildup of fluid. So you're going to see a lot of edema. You'll see the edema mainly in the ankles and the legs. So let's talk about some clinical manifestations on history. If you'll look on page 696, chart 35-2, you have swelling of the legs. These can even go up to the thighs and even up in the abdomen. You know, our patients, if they lie or sit in bed, that fluid can just kind of creep up, and it can even go into the abdomen. Patients might complain that their shoes are fitting tighter. If they wear socks that go up onto their legs or even around their ankles, they can have indentions from all of the swelling. They ladies may not be able to wear their rings because their fingers are swelling. And you also need to ask about weight gain. Remember, daily weight is crucial when you have heart failure. Adults can retain 4 to 7 liters of fluid before pitting edema occurs. So when you think of a 2-liter bottle of pop, that could be 2 to 3 times that. That's a lot of fluid for patients to retain. They also may have nausea and vomiting. That could just result from all the fluid retention. Ascites, they may have that. That's with advanced heart failure. That's going to be a fluid that's accumulated in the abdomen. Frequent urination at night. And then nutritional history. You need to talk to them about their salt intake, what type of food do they consume. They may have increased thirst. Some patients might drink 4,000 to 5,000 milliliters a day because of all the sodium retention that they have. It makes them very thirsty. So that's something you need to ask about as well. The physical assessment, the signs and symptoms that you will see with systemic congestion. You will see jugular vein distension. That's going to be in the neck.
Hey, Julie.
Uh-huh.
I'm sorry. Before you go on, Emily asked a question. She asked if people with lymphedema would be at higher risk for right-sided heart failure.
I don't know. I have not seen that in any information that I've read. So I don't know about that. Okay, so patients will have anorexia and nausea from all of the fluid that's accumulated. It's pressing on the intestine and the stomach, makes them not want to eat. Dependent edema, distended abdomen, swollen hands and feet. I think we've gone over a lot of these. You could have an increase or a decrease in blood pressure. So it's just going to kind of depend on what's going on inside your body. This is a picture of a little lady that is showing all of the signs of right-sided heart failure. And right-sided heart failure can also be referred to as cor pulmonale. I have showed this slide before, but it's very important that the best indicator of fluid balance is weight. So make sure your patients, especially if they're having heart failure, make sure you're getting a weight. So when cardiac output is insufficient, your compensatory mechanisms begin to work to try to improve your cardiac output. So your sympathetic nervous system will be stimulated, and that increases your heart rate and your blood pressure. Also, your renin-angiotensin system is activated, and that is because of the reduced blood flow to the kidneys. You also have a chemical response. That is the B-type natriuretic peptide, and that is, they use the letters BNP for that. This is a peptide that's produced and released in the body when the patient has fluid overload. So anytime you have a patient with heart failure, they're more likely going to have a lab test, and it's just labeled BNP. So you want to make sure you check that. It should be less than 100. If they do not have an acute phase going on, or if they're not having a fluid overload. A lot of times I've seen these up in the 700s and 800s when you get patients that are in with acute phase of heart failure. So just remember that lab work, a BNP. And then again, myocardial hypertrophy, that's the enlarged heart. So history, you need to keep in mind that many conditions can lead to heart failure, hypertension, angina, all sorts of things will lead to heart failure. Let's go, we've talked about nutritional history. Physical assessment, I think we've pretty well covered that. When you're listening to the heart, you may hear an extra heart sound. That could be a gallop. Let's move on to the psychosocial assessment, because I've pretty well covered the medical history, nutrition, and the physical assessment side. So with your psychosocial assessment, it's a very important assessment because a lot of your patients, they're going to have a lot of anxiety, they're going to be very frustrated, and they may be very depressed, because heart failure is a disease. Once they get it, it usually won't go away. It's chronic. They have a lot of acute phases. They're in and out of the hospital. And so these things are going to be very prominent with them. Chronic heart failure, it's a very slow, debilitating disease. Lots of dyspnea. You know, if you feel like you can't breathe, you would be very anxious as well. And then depression, those with advanced disease, they're at very high risk for depression. So it's good maybe to refer them to talk to somebody or help them with their coping mechanisms. So let's talk about some lab work. Electrolytes, those are very important. You can have an imbalance in your electrolytes from the complications of the failure, or it could be a complication of the different medications they're on, especially diuretics, because all heart failure patients are going to be on diuretics. So you need to pay attention to your sodium, your potassium, magnesium, calcium, and chloride, because you know those are all very essential electrolytes. Your BUN and creatinine, a lot of times with heart failure, you have impairment of your kidneys. And when this happens, it can cause an elevated BUN and creatinine. So you need to pay attention to that one as well. Hemoglobin and hematocrit, you can have a low hemoglobin resulting from anemia. If your patient has fluid excess, your hematocrit could be low, be as a result of hemodilution. And then your BNP, which we've already talked about. And again, a normal value on that would be less than 100. You also want to look at the UA. They may have a high specific gravity, and they also may have some protein in the urine. And then ABGs, that's probably going to reveal some hypoxia. Imaging, when you see the chest x-ray of a heart failure patient, they're going to have that large heart. They also could have some dilation going on. And then an EKG, or I'm sorry, an echocardiogram or echocardiography. And this is the best diagnostic tool for heart failure. So you would want to make sure your patient has a recent echocardiogram when they come in the hospital. Now, they won't need one every time they come in. It has to be within probably a couple of years. But an echo can pick up lots of different things. I know you've already had that as a diagnostic test of the week, but just remember, if a patient has heart failure, they have to have an echo. An EKG, that's going to pick up any dysrhythmias, myocardial ischemia, injury, infarction, but it does not determine the presence or the extent of heart failure. Okay, so when we are having planning and implementing, you want to think about gas exchange, cardiac output, and fatigue. Okay, so let's keep going. So to increase gas exchange, you just want to think about, you know, what would you do as a nurse to increase gas exchange on your patient. Some patients that come in, they may need to be put on a ventilator. Some patients not, but some patients will have to be. Auscultate their breath sounds. Think about the position of your patient. Put them in a high Fowler's position if they're dyspneic. And you want to maintain their O2 saturation at least at 90%. And you would just follow however the order was from the doctor on what to set it on. They may be on a cannula, they might be on a mask, so it's just going to kind of depend on what their order is. Improving cardiac output. This is where medication is going to come in. A major role in heart failure for your patients is going to be giving the medications and then monitoring the therapeutic and the adverse effects of the medications, and also teaching the patient and their families about the medications, because they will likely be on a lot of medications and a lot of their management will be done from home. So diuretics, that's the first line drug of choice in older adults for heart failure because of the fluid overload. A lot of them will be placed on the loop diuretics, and you know, they're going to be excreting sodium and they're going to be excreting potassium. So you're going to want to watch their electrolyte levels for that. ACE, this is also a first line drug choice for patients with heart failure. Just kind of depends on the doctor. Some doctors want to start out with an ARB because of how the ACE will cause a cough. Patients with heart failure already have a cough more likely. So ACE and ARBs would be used as well. Calcium channel blockers, these are going to slow the heart rate down, so they may be used as well. Morphine, it can be given to patients in acute heart failure. This will help decrease their anxiety, and if they have that high respiratory rate, it can also slow their respiratory rate. Nitrates, that's the vasodilator. That's going to be for patients in acute heart failure and that have persistent dyspnea. And then digoxin, it can help reduce the exacerbations of heart failure. Beta blockers, these should be started slowly for patients with heart failure, and it should only be given to patients for chronic heart failure. You would not want to give beta blockers in an acute phase of heart failure. Nutrition. Nutrition is very important when we think about heart failure patients. They need to have a vast reduction in their sodium. They don't need to be adding any table salt. They'll probably be placed on a 2 to 3 gram sodium diet. And it's probably wise to go ahead and get a dietary consult while they are in the hospital. Some patients, doctors may order that they can't have any free water, meaning they don't want water sitting on their bedside table, or they may restrict them to maybe 2 liters per day. And your patients may be very thirsty and they may want to drink a lot, but you just have to remember to keep them on that fluid restriction. And then daily weights. And when we do daily weights, we want to try to use the same scale, the same time of day, the same type of clothing that the patient was weighed in the first time. Some other non-surgical options is going to be a CPAP. That is the continuous positive airway pressure. This helps improve obstructive sleep apnea in heart failure patients if they have that. It can also help improve cardiac output, the ejection fraction, and blood pressure, dysrhythmias, things like that. So heart transplant, it's the ultimate choice for end-stage heart failure. After they've tried everything else, this is the last resource that they use for patients in end-stage heart failure. They do also have the VADs. Those are the ventricular assistive devices. and it is where a mechanical pump is implanted to work with the patient's own heart. This can improve cardiac output. These are used for patients who are not candidates for transplants or who are waiting on a heart transplant. And then some other surgical therapies is a heart reduction therapy. They can do a partial left ventriculectomy. It's called a PLV, and that's where they actually remove part of the heart. Okay, to decrease fatigue, energy management, this is, as I said before, it's a major task to help these patients because they're so easily fatigued. So when your patient comes in the hospital, let's say maybe the first day of hospitalization, you don't want to cause them to have a lot of activity. You know, you might have them sit up in a chair for meals, but other than that, you just want to let them rest. Maybe on the second day is when they would maybe have physical therapy come in and ambulate them. It's good to check their blood pressure and heart rate before they're ambulated and then after. And if they have an increase of more than 20 points on their blood pressure or 20 points on their heart rate, that could indicate that the patient, it's too stressful for the patient. They're just not going to be able to do that much activity. So keep that in mind in helping to decrease their fatigue. Try to organize your nursing care to allow for periods of rest and also to allow for less periods of interruption so they can rest. You want to do whatever you can to help them conserve energy. And then they may need to be in cardiac rehab. This can help with their functional level. It can help them get a little more function back, maybe be able to do their activities of daily living. And it can also help them in planning their activities as well.
Hey, Julie.
Yes.
Sorry, Reagan is asking what the difference between a VAD and a pacemaker is.
Well, a ventricular assistive device, I would have to look that up. Let me go back to it. It's placed in the ventricles of the heart. And I really don't know the difference between what those are. So Reagan, you could look that up and report that back to us on the difference.
I think VADs are not meant for long term.
Possibly not. I know there, and I don't know if you all got to do this or not. There was a man that was coming for infusions at Grove, and he had a VAD for quite some time before he got a heart transplant. And I had the students go down and you could listen, and it sounded like a train going off in his chest. It was just really odd. But you may be right, Shelby. Okay.
That's the one that you have to do the ultrasound to take the blood pressure on.
Oh, okay. Yeah.
With like a Doppler, you just do the pulse. Yeah.
Uh-huh. Okay.
This says that VADs are put in when medicines and pacemakers no longer work.
Oh, okay. So it could be used in place of a pacemaker. All right. So one thing you're wanting to try to avoid with your patient is developing pulmonary edema as a result of heart failure. Older patients are at risk for this because of the decreased cardiac output and their heart failure. This is a life-threatening medical emergency. So if they develop pulmonary edema, they need to be treated very quickly. Risk factors for pulmonary edema are acute MI, fluid overload, hypertension, or left-sided heart failure. When you have a patient that is in pulmonary edema, they're going to have high anxiety. This is on page 702, chart 35-3. They're going to be very dyspneic at rest. They're going to have a lot of confusion. They may have hypertension or hypotension. They can't sleep, persistent cough, reduced urine output, those types of things. So nursing care, you're going to want to place them in a high Fowler's position to help with their breathing. Provide oxygen therapy. It's probably going to be at a pretty high flow rate. They may also be prescribed nitroglycerin for the vasodilation. They're also going to be receiving rapid-acting diuretics to promote fluid excretion. Again, they may be given IV morphine. That's to reduce their anxiety, slow their respiratory rate, and reduce any pain that they're having. Antihypertensives, digoxin, and then continual assessment. These patients will be in ICU if they come in with pulmonary edema. So home care management with heart failure, this is crucial that patients along with their families understand how to take care of themselves or their loved ones at home. Chart 35-4 on page 704. Most patients, when they come in the hospital, heart failure teaching is started on the day they're admitted. They may provide teaching packets. They may be watching videos. The information you give them is important, that it's easy to read and that they understand it. Again, you're going to teach about daily weights. Make sure they understand it's at the same time, use the same scale. And then the doctor is going to give them some criteria to go by. If they gain more than 2 pounds overnight or maybe 3 pounds over a 4-day period, they would need to notify their primary care doctor, and he may or she may increase their diuretic. They're probably going to have to restrict their sodium. You need to teach them how to read nutrition labels. A lot of older adults will just use canned foods because it's easy for them. But if you'll look at the sodium content in canned foods, it's very high in sodium. So there's a lot of dietary management that you need to teach patients. They need to know to limit their fluids and alcohol. Alcohol can depress the heart's pumping ability. So they need to understand, they need to limit their alcohol consumption. They need to know how to pace themselves, maybe perform light or moderate exercise. This would help the heart pump more efficiently. And then if they smoke, they need to understand how smoking affects their heart failure. They may need resources, medication, patches, whatever, to help them quit smoking if they are a smoker. Healthcare resources in the bigger cities, there are ambulatory care clinics just for heart failure patients. They manage their medications. They do a lot of health teachings, and this can reduce the inpatient readmission rates. With Joint Commission, there is heart failure core measures. This is not a real good picture. But heart failure is one of those diagnoses that if a patient is discharged and they're readmitted within 30 days with heart failure diagnosis, that is going to be a ding for the hospital, and they will not be reimbursed for that admission. So that's why it's important to try to keep these patients at home, and you don't want these patients in the hospital around sick people. It's best that they can stay home. So health management, a lot of education is vital for heart failure patients. Patients also need to understand what it's going to look like if their heart failure is worsening. On page 704, it talks about this rapid weight gain, 3 pounds in a week. If they have a decrease in their exercise tolerance that would be lasting more than 2 to 3 days. If they have cold symptoms that maybe would last 3 to 5 days, excessive waking up at night to urinate, if they're developing more dyspnea or angina at rest, and then if they would have an increase in the swelling in their feet and ankles. Those are times that they need to contact their primary care doctor or possibly return to the emergency room. Okay, so that's it for heart failure. Now we are going to move on to cardiomyopathy. This is on page 714 in your book. This is a subacute or a chronic disease of the cardiac muscle. The cause for cardiac myopathy is usually unknown. There are 4 different types, but we're not going to get into the different types. We're just going to briefly talk about cardiomyopathy. Usually, most patients that have this are asymptomatic. They don't usually receive a diagnosis maybe until later in the adolescence or young adulthood. Oops. Primary symptoms of cardiomyopathy is dyspnea, angina, not relieved by nitroglycerin, syncope. They may also have palpitations. They may have atrial fib, and also activity and tolerance. An echocardiogram and a heart cath is usually performed to diagnose cardiomyopathies, and then it can also differentiate into the different types of cardiomyopathy that they have. Treatment is going to vary on the different type they have. Medications are usually very similar to those that are used for heart failure. And then toxin exposure, you want to avoid that if their cardiomyopathy has developed in response to a toxin, which would be like alcohol ingestion. And then, of course, further exposure should be avoided. These people that have cardiomyopathies, they need to avoid strenuous exercise. This can increase their risk for sudden death. Surgical management, again, it's going to depend on the type of cardiomyopathy they have. The most common, you can see here, defibrillators, ventriculomyomectomy, heart transplant, you can see those there. Those are found on page 716 for surgical management. And like I said, we're not getting, I just want you to briefly know what cardiomyopathy is and how they're treated. This is heart transplant. If your patient with heart failure or a cardiomyopathy has a heart transplant, this is kind of what it would look like. It's also on page 716, and there's also a chart there that gives you what candidates have to have before they qualify for a heart transplant. Not that you need to know that. It's just interesting to see how a patient has what they have to qualify for a heart transplant. Okay, so let's talk about valvular heart disease. These are on page 705 and 706 in your IGGI book. Valvular heart disease is an abnormal dysfunction of the heart's valves. I don't expect you to know each of the valves. I'm not going to go into it that deep, but just know that there are heart diseases of the valves. And you can kind of tell by the names. Mitral stenosis. Stenosis, you know, means a narrowing of the opening, or maybe the valve is thickening, could be kind of stiff. Regurgitation, that means the blood flow is flowing backward. The valve doesn't work properly. It doesn't close. But again, I don't expect you to know the names of each valvular heart disease. So when patients have valvular heart disease, they may suddenly become ill, or it could just be something that slowly develops over time. A lot of patients that have a disease of the valves, the heart valves, have a heart murmur. Some risk factors, family history of heart disease. You want to ask about any family history of rheumatic fever, possibly infective endocarditis. And also you would want to ask about any IV drug abuse that they've had. You also want to ask them about any history of fatigue, what their present activity level is, and do they have any dyspnea or angina. They will have chest x-ray and EKG. They may have a stress test, may also have an angiography. Again, they would have an echocardiogram. This would just be used to visualize the structures and the movement of the heart. The TEE is the transesophageal echo. And then the ETT is an exercise tolerance test. They try to non-surgically manage valvular heart disease. So that's the first thing they do is rest. They want their patients to conserve energy, monitor their current weight, note any changes, assess the heart rate. People with valvular disease, their heart rate can be regular, they can be bradycardic, and a lot of times they'll have a murmur. Medication therapy, they're going to use the same medications as for heart failure, the ACE inhibitors, diuretics, beta blockers, those types of things. And then one thing to know about patients who have prosthetic valves, if they do have the valve replacement, they have to be on prophylactic antibiotics anytime they have invasive dental or oral procedures. So that is one thing the patients will need to be educated on, is the prophylactic antibiotics that they have to take. Surgical management, they can have heart valve replacements. It restores a more normal functioning valve, and it can also help improve cardiac output. Surgery is only performed only after they start having symptoms of left ventricle failure, and they want to make sure they do replace the valves before there is any irreversible dysfunction. The surgery is similar to the open heart surgery. And then this is a picture of some prosthetic valves that are used to replace the valves. Home care management, they may need home health for a while to help them manage their medications and maybe to schedule their activities that would allow them to decrease their fatigue. Self-management education, they need to understand about their disease process. They may also have heart failure. Medications, again, the prophylactic use of antibiotics, they need to make sure they understand that. And then healthcare resources. The American Heart Association is on the website, and they recommend patients that have prosthetic valves, they can carry a card in their billfold that would let people know if they had an emergency that they need to have those prophylactic antibiotics, or they could also wear the bracelet that would identify them as having prosthetic valves, or states the names of the medication that they're taking. Okay, we're going to talk about infectious and inflammatory disorders of the heart. These are primarily include the layers of the heart, and so They're referred to by the different layers of the heart. So there is endocarditis and there is also pericarditis. Infective endocarditis, previously it was referred to as bacterial endocarditis, but it is usually a result of the infectious organism strep or staph. Risk factors, patients that are more likely to have infective endocarditis are IV drug abusers, valve replacement recipients, patients that have systemic infections like patients who have dental procedures, maybe that have had body piercings and tattoos. Those types of things can also lead to infective endocarditis. Structural cardiac defects, and then getting a pacemaker, those also can be a risk for infective endocarditis. Mortality rate can be very high for patients that have infective endocarditis if the infection is not detected early. So you want to make sure that you understand what the key features are. Those are on page 711 in chart 35-8. They're going to have a fever. Fever could range anywhere from 99 to 103. These would be associated with chills, night sweats, fatigue, muscle aches. These patients will also have anorexia and weight loss. They may have a newly developed murmur. They also may have developed heart failure. Heart failure is the most common complication of infective endocarditis. They also may have a blood clot. An arterial blood clot is also a complication of infective carditis. When patients have infective carditis, they have what they call vegetation, and it's just a mass that shows up in the heart, and some of that mass can break loose and start traveling through the circulation. They also can have petechiae. Those are pinpoint red spots that can be seen on the mucous membrane, the palate of the mouth, also in the skin above the clavicles, and these are just small red flat lesions. They also can develop splinter hemorrhages. These are on the distal third of the nail bed. They appear as kind of black lines or maybe small streaks that would show up in the nail bed. They also may have ulcers, nodes. These are on the palm of the hands and the soles of the feet. And Janeway's lesions, these are flat, reddened macules that show up on the hands and the feet. So infective endocarditis has very distinctive features that show up on the body. The most reliable way to diagnose infective carditis is positive blood cultures. So anytime you have a patient come in for infective endocarditis or there's a suspicion for this, they're always going to have blood cultures, and they will always be positive if that's what their diagnosis is. Also, a new murmur might show up, and then maybe some evidence of endocardial involvement that shows up through the echocardiogram. So most of the treatment is done non-surgically, started on antibiotics, make sure the activities are balanced, that they're getting adequate rest. Surgically, if it's from an infected valve, they're going to remove that valve. Or if it's from shunts, they can remove or repair those. If there's an abscess, they would be draining the abscess if it's in the heart or wherever it might be. Now, pericarditis, this is on page 712. It is an inflammation or an alteration in the pericardium. You know that the pericardium is the membranous sac that encloses the heart. Normally this sac is thin. It is lubricated with fluid, and it helps the heart to move freely as it pumps. But when this pericardium becomes infected, it becomes inflamed, and it can threaten the heart rather than protect the heart. So acute pericarditis is most likely associated with infective organisms. Those could be bacteria, they could be viruses, they can be fungi. Usually it's all respiratory. It can also be associated with post-pericardiotomy syndrome. This is the development of a fever and pleuritic pain after undergoing cardiac surgery. And then it can also be associated with chronic inflammation disorders, chronic constrictive pericarditis. And the chronic inflammation, those could be caused by tuberculosis. They can be caused by trauma, or if a patient has had radiation, that could also be a cause for the chronic inflammation. So assessment, these patients may have pain that radiates to the side of the neck, the left side of the neck, shoulder, or back. They're going to complain of a grating, oppressive pain. Usually it's aggravated by breathing, coughing, or swallowing. And their pain is worsened by the supine position when they lie flat. The only way their pain is relieved is by sitting up and leaning forward. They're also going to have a pericardial friction rub, and this is a rubbing sound, which is typical. It's fluid that's around the heart. It's kind of a sound that you hear when you walk on fresh snow. You know how that sound is. That's what you're going to hear if you hear a pericardial friction rub. Lab work, you're going to see positive blood cultures. You're also going to have an increase in your white blood cell count. You also have, hold on. You may also have cardiac enzymes. They may also be elevated with pericarditis. You would also want to do throat cultures, and your diagnostic procedures, again, are your EKG and an echo. Patient care, you're going to administer their medications, medications for pain. They may require some oxygen, obviously antibiotics. Prednisone, if it's not bacterial pericarditis, you can offer prednisone. And then if it's caused by a fungus, they would be on an antifungal. Encourage bed rest, and then position for comfort. They may want to be sitting upright and possibly even leaning forward. Okay, so that is the end of our theory time. What time is it? 10:02. Let's go ahead and take a quick break. And then remember, let me stop sharing this. Remember, when you come back on, have your laptop on, open for the quiz, and sign into Zoom using the same, I'm just going to leave this open. You'll use the same link that you used to sign on for this theory. Sign on with your phone so we can monitor you with your phone. So let's take a quick 10-minute, let's just be back, try to be back by 10:10.
Can I have my sister's laptop sitting next to me so I can have my PowerPoints pulled up, because I keep taking notes on my computer?
Okay, that's fine.
Okay, thank you.
Uh-huh.
Hey, Julie.
Uh-huh.
When or what are you wanting us to pull up on our phone? I'm sorry.
Oh, Zoom.
Okay. And then are we using Exemplify, I imagine, on our laptops then?
Yes.
Okay.
Okay, looks like most people are back.
Hey, Julie.
Uh-huh.
Sam said she's trying to get her phone to work, but it's taking a long time to load because she doesn't have very good service right now, I don't think.
Okay. This is a good time to make sure everything is going to work correctly because we will be having our third exam on Monday morning at 9 o'clock. So if you have any glitches or issues, make sure you get those resolved, by Monday. Because it will be a lot stricter on Monday than I'm going to be today. This is just kind of a trial run that we're doing the quiz.
Hey, Julie.
Uh-huh.
It's Sasha. Hey, can you look at my deal and see? I have jacked with this stupid phone trying to get it. I got my computer and my screen in my hands, but I can't really get my face. Like, I can crunch down, I guess. I don't know how do you guys want this set up? Because it's hard.
Yeah, I know it is, but
I don't got a phone holder deal. If I got like a tripod deal, I could probably try that, but I'd have to buy one.
Yeah, let's
Because I could
So
try to
I'm
get a fire, but it
making
falls.
it, and I'm using
how she does hers. What is that? Oh, yeah.
this is just like a random jar I have in my home, and I put towels in it to place my phone in.
Oh, okay. Good idea.
I got mine on
Very
pillows and towels.
creative. Very creative.
Say it again. What is it?
It's just a jar that she put towels in to hold her phone. So you may have to get creative.
Julie.
Okay, Julie.
Yes.
Oh, good.
I sent you a text.
Yeah, and I was going to call you, but I don't have your number.
Oh, we had an emergency last night, and I ended up with my fiance's grandparents, and so I'm in a hotel room right now. And I didn't bring my book, and my PowerPoints are on my computer.
Okay. When will you be home?
I'll be home probably around, hopefully, 5 or 6 this afternoon.
Okay. You can just let me know when you're home, and then you can do your quiz.
Okay, thank you. Sorry.
It's okay. Okay, so Debbie, they're kind of having a hard time getting their phone to where it needs to be. So I told them we need to try to work out all these bugs before Monday, before our test.
Yeah. Julie, I bought one of those like a charger thing, and it looks like this. And it's got a slot to put your phone on. It holds it while you're not.
Okay.
You could get them at Kohl's.
Okay. Thank you, Stacy.
What do you want us to show you in the video? Like have it showing our laptops or?
Well, I'm not going to have you show me anything. I just want you, this is just kind of a practice, but when we're testing, you're going to have to show all around the room to make sure nobody's in there. You don't have any books out, no papers, just your laptop, and then your phone will have to be set to the right to where we can see your face and your laptop. You can see Chad. He's kind of got to where we can see both. Tiara, we can see her, Allie, Melissa.
Hey, Julie. So I have it right here. My books are here, but you can see that I'm not like, do I need to move everything around so that, but you can see I can.
Right, yeah, you're fine.
Okay.
Elizabeth, when we test, we'll have to be able to see your laptop, what's on your screen.
Kathleen,
do you want to go ahead and read the instructions so that everybody knows right now what needs to be done on Monday for our test and be prepared for that?
Let's see. We can do that. Let me run down through these. First of all, before you ever even open your Zoom app on your phone, make sure you've got your phone set on like airplane mode or not vibrate, because we don't want phones beeping and buzzing during the test as a distraction. So I don't know if you have to do that, change your settings before you open Zoom. So make sure you've got it where it's not going to ring, no ringtones, no vibration or anything during the exam. Do not disturb. You don't want text messages coming through.
Hey, Kathleen.
Well, that was no internet.
Yeah.
Yeah, airplane mode will not work. We'll have to do like the do not disturb.
Do not disturb. Okay. Okay.
Yeah.
Let's see. We're trying to really stress the exam etiquette, and we're going to have some more guidelines on that is going to be coming out. We're working with second year too, just for you all to be doing things anytime you're on a Zoom meeting so that it's not a distraction to others. So we'll be coming out with some more guidelines on that. But especially on our exam, we're really about the test security and you all being honest. And for the most part, we don't think we're going to have issues, but it's awful easy to cheat when nobody's looking, and we just don't want that to happen. So we're expecting academic honesty. If you during the exams, what we're going to do is, when, like Julie said, you're going to give like a panoramic view of your room, your test area, your screen, to show us that you've got the exam downloaded. So once you're downloaded, you can't do anything else on your computer except the exam. A change that Julie's not aware of that we've been talking to second year about this morning is that I think now we are going to allow pencil and paper. You are going to have to show, yes, you're going to have to show that your paper's blank before the exam starts. But second year students really struggled with their dosage calc. Those that are visual and they have to write it down. Some of them really struggled with their dosage calc questions. So I was not aware that NCLEX does allow you to have a whiteboard when you take NCLEX for writing out dosage calc questions. So we are going to change that, and that wasn't in your original policy. So we'll get that fixed too. But you will be able to have paper and pencil. You're just going to have to show us that your paper's blank before you begin. We'll do roll call at the beginning. So we're going to have you state your name and then show us your area with your phone or whatever device you're using for Zoom. And then we want it placed, this says on your right side, but I think Tara has hers on her left. I think that was what I saw, just so we can see you, your screen, your area immediately around you. That's the main thing. Then once you announce yourself, you go back on to mute and you stay muted the entire time. When you are finished, or if you have a problem during the testing, you're going to write a chat question because we'll be watching. But when you're finished, you just say finished in your chat, and we will have you show us your area again, and you can leave the Zoom meeting once you're done. It will be recorded. We will activate record when we get ready to start an exam. So did I miss anything that you Julie and Debbie, that you
Yes.
Hey, Julie.
Yes, sorry.
Can we leave the Zoom now? I'm still on question 4.
Oh, Kathleen, we're still not getting good pictures. Kathleen, did you want to say something before people start getting off?
Before you start getting off, take a look at the screen and see what we're seeing, because sometimes we're just seeing the student's arm. We can't see faces. We're seeing back of heads. Some of you are sideways, and I don't know. That's specifically, who did we say? Jade and
Yeah. Taylor's now, as she was.
So especially Monday morning when we get ready to test, when we have you say your name and we have you give us a visual of your area, we want you to we want you to look at the screen and look at yourself and see what we're seeing, because we need to be able to see your faces, and we want to see your computer screen too, but more importantly, we want to be able to see your face in your work area. So just
Is mine okay, or?
Who said that?
Christy. I have my phone sideways, but I couldn't get it to sit up straight. Can you see me?
Let me find you on here. Do you see Christy, Julie?
Yeah. I think you're fine. I can see your laptop and I can see you.
Okay. So am I okay to go now?
Yes.
Thank you.
You're welcome.
Julie, do you see my area very well, or I'm just trying to figure out if I'm going to need to be in a different area?
Yes, I can see you, I think, well enough. Whoops, it just flipped. Casey, yours is going to have to kind of be beside you so we can see your laptop.
What about mine, Julie? Shelby Gandy?
You're sideways.
Is that okay?
No, we've got to have it upright.
I mean, your picture is sideways.
Yeah.
So
now,
when you turn your phone, it turns your picture sideways. Is that a setting in your phone?
No, I just had my phone laying on its side, like.
Yeah.
Is your phone locked in a certain rotation?
Yeah, that's what I meant about the setting.
It's locked in upright.
If you unlock it, your
you'll
picture
have to
should
unlock
move
it so when you lay it on its side, it'll flip around and it'll show. We need a bigger picture.
Wider margin. We need wider margins, right?
Yeah.
Look like a.
Am I
So
there, that works, Shelby.
That works.
Okay, so that's good.
You might have to scoot it back a little bit so you don't have to lean forward all the time, because you're just barely in the corner.
Your face is just barely.
The way my desk is, it's got this.
Yeah.
Oh yeah.
I can't put it any further.
Can you pull your laptop out when you're testing? You won't have your book.
I wonder if your phone is not high enough either. Almost like she's having to hunch down.
So if I put it on something, would that be better?
Put a book under it or something, that might help.
Yeah.
Okay.
That looks good, Shelby. You got, yeah.
Okay.
Hey, Kathleen, it's April.
Yes.
Do I need to turn my computer more sideways, or?
If you can. I don't want anybody being in a position where they're not comfortable to test either.
Well, I just didn't know, because you guys said you wanted to see the computer, but
yeah,
in order to see me too, I didn't know.
Yeah. Well, it's more important that we can see you.
Okay. So this would be okay?
Yeah, that probably should be okay.
Okay.
Is Callie flipped sideways, or is my phone fine?
You are good.
Okay, thank you.
Kathleen.
Jade, is that Jade?
Yes. For Monday, I'm gonna get like a desk set up I didn't have time today to get one set up, so like I won't be here. So like I'll be able to like show everything.
Okay, and we can do a practice run if any of you want to do that, and just send us a message. We can look and see your setup, so we'll be ready.
I would like that because I'm not going to be at my house either. I'm going to be going to my mother's where hers is more open.
Hey, that'd be fun. We could do a Zoom with you. Let's do a fun Zoom time.
Yeah, that just take a second just for you to message and us look.
Yeah.
Can you check mine to see if I'm okay?
Leanne, your picture is real narrow. Have you got your phone upright?
Yes, ma'am.
Turn it sideways and see what it does. Lay it on its side. Okay, there you go. That's better.
Okay.
Now
Thank
it's
you.
wider. Yeah.
We want we want you guys to be in a comfortable position so that you're relaxed while you test. We don't want it to feel awkward for you, but
Misty, I can barely see you from far off.
So you have to see if so I wasn't good, was I? Because you see my.
Yeah, we're seeing.
You were far off.
The back of your head. We're seeing more just testing area. If there's a way
If I move my desk like here, maybe away from the wall, this would be okay.
Yeah.
Okay.
Sound like we had some valuable input from someone there.
Is it better now that I scooted that closer? Because when I'm testing, I won't have this book here, so it'll just be like.
Your margins are narrow.
Have you got your phone upright? There you go. Well, you turn your phone on your side.
Turn it on the side.
Uh-huh. You're going to have to set your rotation in your settings on your phone so that your picture will stay even though you rotate your phone. You may have it locked. There.
And you said we can go ahead and leave if we're not finished yet.
Yes, you can.
Okay, I have quite a few left, so.
Misty, if you can set your phone up on something, it might be better too, like a book under it or something like that, so it's a little bit higher.
Okay, I have a question. If we don't finish in the time frame that's on the Exemplify, what do we do?
Well, that's why I'm talking with Cindy Brown right now because I only put in an hour, but it's probably going to shut off. I'm figuring out how I can open it back up.
Okay, because I was like, some of these questions, like I'm having such a hard time finding, and I'm like, oh my God, there's no way I'm gonna
get two. I'm only on question 5, actually 4, because I have 4 flagged. So I'm only done with like 4 questions.
Wow.
I don't know why I'm having some.
I'm not making it very far either.
Neither am I.
Is anyone struggling with the question where it's asking which medication is the treatment of choice? Wait, hold on. That's not a medication. It might not be a medication. The treatment of choice for end-stage heart disease. Would that be, never mind. I think I'm just not looking at these questions the right way.
Hey, Julie.
Yeah.
Okay.
Anybody have a question?
I was just thinking, is this setup okay?
We can't see you.
Who is this? Oh, Kenny?
Yeah.
Yours is too far away.
He's in the witness protection program with Vicki.
Is mine okay? Because I'll go ahead and get off if it is and do the quiz.
I couldn't see your screen real well, Elizabeth.
There's like a glare. I have my office is complete windows, so. I can just tilt my screen, I guess, when I test. That's the best I can do because that's the end of my desk.
Okay. Yeah, that's good. Your lighting keeps kind of going in and out.
Yeah, I have a bunch of windows and it's super windy and get ready to storm, it looks like, so. But, one light, I don't know if that helps any, but.
Julie, am I good right here? I moved my phone to the other side.
Yeah, you might scoot it back just a little bit.
My phone back?
Uh-huh.
Okay. Is that better?
That's perfect. Yeah.
Okay. Thank you.
You're welcome.
Is that better at all? I know it's kind of dark, but.
Is mine okay? This is Adam.
Doesn't Adam need to go back by the fish tank again?
He is by the fish tank.
Put it by the fish tank?
No, you're fine like that.
Oh, okay, cool.
We heard your fish tank the other day.
Oh yeah, it's a good little fish tank. So
What is it?
There's a little, I think it's a cichlid. His name's Wally.
Oh.
Anyways, I got my quiz to do, so I better hurry.
Okay. Thank you.
This is not where I will be testing, so sorry if it looks weird.
Julie, can you type in the review password?
I don't think we're going to do the review. I think what we're going to do is I don't think very many people are going to get finished in an hour. I didn't realize it would take this long. So I will post the paper quiz on D2L. You can finish it up that way, and then I'll open up a Dropbox for you just to drop it in the Dropbox. That way you don't have to rush and you can take as much time as you need. So I'm preparing an email right now.
Okay, so is it okay if I go ahead and get off here then, because I have to go and get my kids' school supplies?
Yes, that's fine. Yeah, everybody can go ahead and get off. Just know that your exam is going to shut off in an hour, which is probably just about 5 or 10 minutes. So I'll go ahead and post the paper copy and you can continue working on it.
All right,
If
thank
I
you.
already finished, do I need to do the paper copy?
I'll give you the review code if you want to do it. Are you okay with, did you rush? Do you feel like you rushed?
I don't know. I thought I did well, but apparently I didn't.
Let me look. Well, I don't see where it's uploaded.
Oh, I have to, it said to either do the review or do upload.
Okay. Let's just do the paper copy because I think that's just going to be best for everybody. Is that okay?
Yes.
Okay.
So does that mean we have to go back through and re-answer everything?
No, I can go ahead and submit what you have. It's going to take what you have anyway when it shuts down.
Mm-hmm.
And, but I mean, I don't know if you're going to be able to remember which ones you answered and which ones you haven't, unless you can decipher that on when you take the paper quiz.
Mine just uploaded.
Okay.
So.
So if you can remember which ones you answered, I can see what you answered on your quiz, and you don't have to re-answer them, but depend on if you can remember what you answered. Sorry, this didn't turn out like I thought it would.
Whoever that is that's in that on that Samsung, they're in a car.
It's Bonnie.
Oh, I didn't know. Bless her.
So you said just go ahead and submit, correct?
Yeah, because when it shuts off, it's going to submit everybody's anyway. And I set it for an hour and I can't adjust it after we've started.
Okay, and you said don't worry about the review yet?
Right. We're not going to do the review because I want you to be able to finish the test without me giving you the answers. That would
Oh,
give you.
mine's done, so
Okay.
I'm at that point to where it's either load or review.
I would go ahead and submit it, Kenny, just in case. Do you feel like you rushed?
No, I just think that I don't know if things were written down because I think I abbreviated some stuff.
Well, I can adjust that, but go ahead and submit.
I mean, I felt like I felt like there was a lot of questions that were extremely difficult. And since we didn't have the PowerPoint for today,
Yeah, it's on D2L. I posted it yesterday.
I didn't see it.
Yeah, it says student copy heart failure.
Well,
I wouldn't be able to use my PowerPoint because it'd be on my computer.
yeah, there's a lot of people that couldn't find it this morning, evidently.
Yeah, well, I put it up yesterday.
Well, you know, it's on my computer, and the exam software won't let you use stuff on your computer,
Yeah,
right?
okay. I'll just give you a paper version and give you instructions to take the quiz on paper. Okay?
That's fine.
Sorry.
I think I have to shut my
Yeah, you all can
my
get on.
meeting off because see,
We're trying, guys. We're
because
trying
I'm on the
hard.
same internet.
This was good practice.
Sorry.
Yeah, it was. All right.
Okay, go ahead and get off. It's gonna take your test, your quiz here in just a minute anyway.
Julie, is my camera good? Or do I need to fix it?
You may need your, you still have a very narrow picture, and I don't know, can you turn it on its side? There you go. That's
Is
much,
that good?
you might scoot it back just a little bit. And you're gonna skip it down. There you go. Is that good, girls?
Yeah,
Maybe-
that's much better.
Yeah, I think that's good. Yeah.
All right, thank you.
Thanks.
Thank you, Chance.
Okay, Stacy, go ahead and end your meeting.
It's frozen.
Okay, I removed her.
How do you remove them? How do you?
When you hover over their picture, there's a blue square with 3 little dots. If you click on that at the very bottom, it says remove. And I clicked that and it took her
Oh,
off.
okay.
So what I'm going to have to do with this quiz is I'm just going to post it on D2L.
Okay.
I think it was
What do you girls want to do for lunch? Susan and Debbie are talking about lunch too. We want to have, will they deliver? I guess we could deliver it, pick it up out
or we
there.
could go pick it up.
Julie's going to come eat too.
Oh, she is? Well, if Julie's gonna come eat, maybe she can pick it up for us. But yeah, I want to be included in that.
Yeah, Susan, does Debbie too?
Debbie brought something and
Okay.
Dora's going home.
Okay, so just Susan wants whenever we decide.
Let me know.
Okay, we will.
So for this quiz, I didn't realize it would take this long. I think this proves they're not printing their PowerPoints. They're not getting in their book, because if they were familiar with their book, they would know where to find these.
They would.
So I'm just going to post a paper version of the quiz. It's 20 questions. I will tell them just to pick 10 and answer them and then submit it in a Dropbox. You think that's fair?
Yeah.
Then they'll get their 10 points. So I guess you just learn as you go. Kenny, I guess you heard that, said, you know, he couldn't answer some of them because the PowerPoint wasn't posted. I posted it yesterday and it was there. So he apparently didn't look.
Yeah, and Bonnie said, well, she couldn't see her PowerPoints because exam software won't let you look. Well, print them. You've got to print them off.
So they didn't print them. They're familiar with the book. So whatever, I'll just send them an email and they can still get their points. So.
And Julie, that's nothing new. That's the same way that Kenny has done me in the past, you know, even trying to get enrolled for EHR. And I said, you can do that. You're No. And he said, no, I've tried. You didn't even send the right number. And then the other student said, yes, we're on it. Whatever.
Well, Stacy Keene emailed me this morning, panicked. I can't find the PowerPoint. So I told her exactly where it was. And she said, oh, I just didn't see it. I see it now. So it says student copy heart failure. I don't know. So anyway, what do I want for lunch?
I don't care. What sounds good?
I don't care. I'm just frustrated with these students.
I am too. And I think it's going to be a fiasco on Monday.
Yeah, I think it is too, because they weren't paying a whole lot of attention.
Oh, yeah.
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 It shut me off. I didn't get done with my test.
Oh, yeah. I'll go off.
Well, I'm going to finish this email real quick so they won't panic. And then you all can call me or text me and let me know what to go pick up.
Okay.
Okay. Bye.
All right. Bye.